So I'm here with Andy Gettinger, and we've been talking about this really amazing story of a large EHR implementation, and but more than that, 20 years of experience working in health IT along with it. So certainly some perspective there, Andy. And I'm just curious, when you think about the health IT industry, what needs to change?
Well, we now call an electronic health record not an electronic medical record, but an electronic health record. And the distinction's important because most of us would define it, as does the Office of the National Coordinator in HHS, defines it as including the personal health record or the patient's health record, the PHR, and together with what is recorded by clinicians in a healthcare environment, that PHR becomes increasingly important. But I'm going to go back to the EMR. And the EMR, that documentation of the process of care, was originally a tool of clinicians. And you wrote in the chart, usually with encrypted, i.e. illegible handwriting, what information was important to carry forward so that you could provide care and others could provide care with you, taking care of the patient. As we've moved to the computer, and as the regulatory environment has gotten more rigorous in terms of what is reimbursed and what are the requirements for reimbursement, there are many more entries into the record, some of which actually don't help provide care. And we also suffer from something that is not unique to the healthcare industry. I call it the tyranny of cut and paste. It is so easy in a computer system to cut and paste old information so that we have longer and longer notes now. But what we've lost is that original contribution of that encounter, which is so essential when you start thinking about trying to characterize a patient's experience and what information needs to be shared. So I look at the EMR and the EHR as a wonderful potential tool, but one which actually needs to be adjusted to be much more clinician focused. The current EHRs are also not very clinician friendly. And what that means is, in fact, I hear this from many of the doctors and nurses and pharmacists that I interact with, who designed this system? You know, it certainly wasn't designed by me or anybody that provides care. And in fact, there is some truth to that, these systems are designed by vendors who come and observe, but it's basically non-clinicians who decide how the software is going to look, and they don't necessarily know how we use that tool. And in fact, that's probably the biggest transition that our organization has had to face, which is going from a customized tool designed by clinicians, myself and some of the other clinicians on the team that developed our legacy system, to this new vendor software, which is incredibly complicated. Much more powerful in terms of all the different things it can do, but way more complicated. It is so non-intuitive. Once you learn it, you know where to go. You get that muscle memory kind of thing in your brain, and you know to put the mouse here or to use the keyboard this way. But if you don't have that knowledge, it can be bewildering, which is what we experienced last year, and I think what every other institution experiences when their clinicians make this transition.
On behalf of the Tuck School of Business and the Center for Digital Strategies, thanks so much for sharing your perspectives and learnings with us today.
Oh, it's my pleasure, Eric. Thanks for inviting me.